Good afternoon, everyone. Now, I know that everyone was a little bit late for the lunch, but now we need to resume our program. Now we are presenting this session for ultra low contrast PCI. It will be presented by Dr. Breda Hennessey from Spain, Madrid. She works in San Carlo Center, who are well known with adoption of this ultra low contrast technique. And Dr. Breda, can you go ahead, please? Because we are a little bit late on our schedule.
So thank you very much for the very kind introduction and for the invitation to share some thoughts on a topic that's very near and dear to my heart, and for this wonderful opportunity to visit Dubai. So I suppose the question we need to ask ourselves is, why do we need to reduce contrast? And I think the patients that we're now treating in our cath labs on a daily basis are increasingly complex. We have patients with chronic kidney disease, increasing numbers of patients with diabetics, and other risk factors that leave them at risk of contrast-induced kidney injury. There's a number of different clinical situations that we encounter that prohibit large volumes of contrast. And I think as interventionists, we're increasingly embarking on ever more complex PCI. There are certain situations in CTO PCI where contrast injection is not prudent. And also in the event of complications such as dissections that are iatrogenic, or if you find yourself with a patient with SCAD, it's not prudent to inject contrast. And in addition to this, we have a very widely available toolkit and a very easy to learn skill set that helps us perform PCI with significantly reducing our contrast burden. So the first concept I'd like to introduce is this concept of renalism. So I think as interventional cardiologists, we tend to pick out patients that have chronic kidney disease and completely change the way we approach these patients. We treat them completely differently. And I think you can see here on this slide that patients who present with a myocardial infarction, who have chronic kidney disease, we're treating them differently. So as you can see here, they're less than half as likely to actually get an angiogram. And I think most people in this room would agree that if you have a heart attack, you should probably do an angiogram. But as you can see, we're not doing that. And I think there's evidence of this in even more contemporary trials. So if you look at the ischemia trial, and if you look at the standard ischemia trial, 80% of those randomized to an invasive arm got an angiogram. But if you look at the ischemia CKD trial, only 50% of those that were randomized to an invasive arm actually got an angiogram. So something is stopping us as physicians from doing this. The only difference between these two trials was the presence of CKD. So something is stopping us. And I suppose the fear that a lot of clinicians would have is that if we perform interventions on patients with CKD, particularly those at a more advanced stage, is that we will result in these patients requiring dialysis. And of course, there's evidence for that. And again, in the ischemia CKD trial, what we can see here is that those randomized to the invasive arm had an almost threefold increase of requiring dialysis procedurally. And this was seen in the follow-up out to 2 years. So we can do some harm, of course. There is a cost to being conservative in these patients, especially in those patients who present with a myocardial infarction and have CKD. And what we can see from this large registry is that if we treat these patients conservatively across all spectrums of GFR, so if we look at, from patients with normal renal function out to the more severe cases, the patients that were managed conservatively in the context of an ACS, they do worse. They have higher death rates within 1 year. So we need to do better at how we manage these patients. I suppose the downside to performing invasive coronary interventions on these patients is contrast-induced acute kidney injury. And this is some very interesting data that was from the ADAPT DES trial. So again, this is a large trial, over 7,000 patients. The overall acute kidney injury rate was around 6.5%. And what I think most people would expect is that patients with dialysis would tend to do worse in terms of outcomes. But what this study actually showed was that the patients who have CKD, who then developed a contrast-induced nephropathy, these were actually the patients who had increased rates of net clinical adverse events. So these are the groups of patients that we really need to target. So there's a number of measures that we can do to reduce contrast, and that starts with patient preparation, operator awareness, hydrating your patients, stopping nephrotoxic medications, all very simple measures. I suppose in certain situations you need to think about implanting an Impella, particularly if the patients are at risk of hypotension during their procedures. These interventions are heavily reliant on IVUS and physiology. These are patients that, if possible, you should go radial. And we need to change the approach of how we do our diagnostic angiograms in these patients. So we should aim for a contrast volume to eGFR ratio of less than 1. And for a diagnostic procedure, in most cases, 3 projections is enough. 3 cc's of contrast per injection. So for the left coronary system, that's your epicranial and your epicaudal. And for your right coronary artery, it's an LAO cranial. And in most cases, you get all the information that's necessary. And if you have a doubt, then that is where you use your invasive physiology or your IVUS catheters to further assess. And in terms of prehydration, it's not straightforward, it's not simple. And I suppose the biggest body of evidence we have for this is based on the Poseidon trial. So this was a trial of around 400 patients. The average eGFR was 48, so it wouldn't require an absolute ultra-low dose contrast intervention, but certainly, they have renal dysfunction. And what this showed us was that at the 6 months event rates, MACE death, myocardial infarction, dialysis, were higher in the control group compared to the patients that had targeted LVEDP guided hydration. So these are groups of patients, if we just blindly hydrate them, we can cause them more harm by putting them into pulmonary edema. So it's worth bearing this concept in mind. So the idea of ultra-low dose contrast intervention is primarily based around this idea of contrast volume to eGFR ratio of 1. And this is primarily based on a study by Brown et al. And essentially what it showed was that if you keep your contrast volume to eGFR less than 1, you are unlikely to harm your patients. Your overall risk of acute kidney injury is low, your rates of dialysis will be around 1%, and you are unlikely to harm your patients. So therefore, it's relatively safe to proceed with PCI in these cases. So in simple terms, if you have an eGFR of 17, that is the amount of contrast that you can use for your interventional procedure. So when performing ultra-low dose PCI, it's important to kind of have a mental checklist available to you, just to keep contrast hygiene in mind. And there's some simple things you can do to avoid contrast puffing. So starting from engaging your catheter, well, rather than puffing contrast to check if you're engaged, you can actually inject saline and look for ECG changes. So it's a very simple way to do it. Alternatively, you can advance safer coronary wires. It's important to use a very exaggerated J-tip curve to gently advance it down the wire. or down the vessel rather. If you have dynamic coronary road mapping, well, this is a very powerful tool that will allow you to do so. But if you don't, then there's an easy way to do it. You project their diagnostic pictures in the cath lab the day that you are doing the stage procedure. If you create an anatomical landmark, that can also help. So wiring your side branches, important areas of calcium, that sort of thing, that can help for later positioning your balloon and your stents. When should we use the contrast and how much should you use? Well, previously, as I've mentioned, you have to bear in mind your contrast volume to EGFR ratio. You can dilute the contrast with a 1-to-1 ratio with saline to make it go a little further. If you do so, you need to use higher frame rates because it washes out of the vessel a lot quicker. And the idea is that you only inject contrast when there's a clinical need. So that is, clinical instability, severe unexpected chest pain, and it is prudent to perform a final angiogram just to make sure you don't have any complications such as wire exits. I suppose deciding what to treat and how to treat it, I think as interventionists we're very accustomed to using contrast to decide that, but we need to switch this over to embracing your physiology and your IVUS with co-registration instead of this. So I'm going to take you over to a case we performed recently to show you some of these techniques. We performed this case in Clínico San Carlos a few months back. So this is a 72-year-old gentleman, a very typical patient, multiple cardiac risk factors, significant diabetic history, insulin dependent, had severe vascular disease, bilateral bypasses, multiple toe amputations, CKD stage 4. And he presented with a first presentation of acute coronary syndrome, 2-week history of lower limb edema, PND, orthopnea. His ECG had some T-wave changes in the lateral leads, and this was his first echo, which showed an LV ejection fraction of 36% with moderate mitral regurgitation. He was anemic, and he had an EGFR of 17. So he went on to have a diagnostic angiogram at one of our peripheral centres, and I think what you can appreciate here on the cranial shots is that there's a very long segment of diffuse disease in the proximal and mid-LAD. The severity is a little ambiguous. We felt that it was most likely there were some areas that were severe, but we decided to perform physiology just to check if this was functionally significant, and as you can see, it was. And on the caudal shots in the proximal circumflex extending into the OM, we have another lesion, which again is a little ambiguous as to the severity. Overall, we felt that it was likely severe. We did perform physiology, and again, this was found to be positive. His right coronary artery was unremarkable, just a mild disease. So we calculated this patient's syntax score. His syntax score of 26, a PCI syntax score of 56.3, giving him a 4-year mortality for PCI of 47%. His CABG syntax 2 score was 40, giving him a 4-year mortality of 15%. And based on the scores, there was a treatment recommendation for a bypass. Now, this patient clearly has disease that may be more best suited treated by a bypass. He's multivessel disease, he's a diabetic. This patient was discussed at our local heart team meeting. Ultimately, the surgeons met with the patient and a bypass was offered, but the patient refused surgery. He did not want to undergo the surgery, so we had to rethink and we offered him an ultra-low dose contrast intervention. So this was our procedural plan. We knew from the diagnostic that his femoral access was challenging and that he had no radial access. So we planned to perform safe femoral access using ultrasound guidance, which is standard practice in our centre, with a plan for meticulous hemostasis to avoid any bleeding issues afterwards. In terms of the diffuse disease in the LAD with angiographically significant calcium, we planned to perform invasive physiology again with a pullback and guide our therapy using IVUS. In terms of a CKD, we know that we can only use 17 cc's of contrast, and in order to minimize this, again, we're going to use our physiology and IVUS. So this is our setup. So what you can see here is Javier Scaned is just injecting some saline, and he's watching for the ECG changes. And I'll show you a still frame of that in a second. I have speeded up the wire advancement here for anybody wondering, but what you can see is that we've projected the diagnostic pictures on the lower left-hand corner to use as a roadmap. So this is taken directly from the case from the polygraph, and what you can see is when you inject a T-wave change, or when you inject saline rather, you have very, very pronounced transient T-wave changes. So it's a very simple thing to look out for, and it can be very helpful. So we moved on to assessing the LAD. So we obtained an IFR of 0.69 distally. And what you can see on this pullback is that this vessel, unsurprisingly, is very diffusely diseased. There's a very diffuse pattern on this pullback. And it's certainly going to be a challenge to get a functionally acceptable result in this case. We moved on to co-registration. As you can see here, we've used the wire instead of contrast injection. And by treating a very long segment of disease in the proximal and mid-LAD, roughly 54 millimeters, we can expect an IFR of 0.94 at the end. Of course, that's not the whole story. We moved on to IVUS to assess the vessel. Of course, we're bearing in mind our mental image of our co-registration. And on the pullback here, you can see in the more distal segment, there's some disease. In the more mid segment, there's mixed plaque, fibrolipidic, some areas of calcification. But overall, the calcification that appears severe angiographically, when you actually look at the IVUS, it's probably superficial and is probably not going to cause us too much trouble. Moving on to the proximal segment, again, there's some diffuse disease, but there seems to be a good landing zone before we go back into the left main stem. So we were fairly confident we were going to be able to get good landing zones. So we performed our co-registration. We obtained a distal reference of 2.75, and we're just going proximally here to look for a proximal landing zone. It measured 3.5, and overall the length was very similar to what we found on the coronary physiology. So in terms of this treatment, we've pre-dilated with a Wolverine balloon, seemed to expand very well. We then advanced a 275 by 32 millimeter stent to our distal landing zone, planted at high pressures. Here we're using the sync vision technology just to check that our proximal stent, which is a 35 by 28 millimeter stent, is overlapped with the previous one. We've post-dilated with the 3.5 balloon and then performed a pot. And again, we're using the sync vision technology to make sure that our balloons are expanded. So it's a very nice element to the Philips system that we use in Madrid. Of course, we need to check our results because we haven't injected any contrast at this point. So we performed a pullback. In the distal part of the stent, overall, the stent seems to be reasonably well expanded. Moving to the mid-segment, and if you remember, this is where we had our calcium. Overall, the stent seems to be quite acceptably expanded. There's no significant areas of under-expansion. And then just moving more proximally, again, the stent is well expanded. Obviously, on these runs, you're checking for proximal and distal dissections as well. So we moved on to the co-registration, and again, we're double-checking our areas, and as you can see here, we had some excellent areas, but given that Javier was doing the case, physiology is always a feature, so we checked our results. When we did our pullback, again, this is a very diffusely diseased vessel, but what you can see here is there's no significant areas that we need to treat. There's no big step-ups. So overall, a very acceptable functional result. And this is our first injection of the case. So at this point, we have used 5 cc's of contrast. So going back to our checklist, we've used our saline to inject, we've advanced the wires using our diagnostic images, we've used our anatomical landmarks, we've used 5 cc's of contrast, and we've heavily relied on the IVUS and physiology. So we decided that it was probably safe to go ahead and treat the circumflex, given that we'd only use 5 cc's of contrast. So we obtained an IFR distally of 0.81. And what you notice here is that the pattern of disease is very different to that of the LAD. We've got a very focal area. And you can see here we're just performing a co-registration using the wire rather than co-registration, angiogram for co-registration. And what you can see here is that if we treat a very short segment, roughly 20 millimeters, we can expect an IFR at the end of around 1. Of course, we performed IVUS as well. So in the distal part, again, mixed plaque, maybe some areas of calcium. Overall, it appears to be very superficial with an arc of less than 180, and moving more proximal, we got the sense that there was a landing zone very near to an AV branch. We moved on to our co-registration. We obtained a distal reference of 2.6 in the distal vessel, and then we were just looking for our proximal landing zone. Again, we're looking for that little branch, and we obtained a proximal reference of 3.5, and again, overall, a length of just over 20 millimeters. So we moved on then to wiring that AV branch to use it as an anatomical marker, to use it as our skeleton. And we moved on to treatment. So we pre-dilated with a 2.5 balloon. It expands very well. We advanced, you'll see now in a second, we've advanced a 2.5 by 28 millimeter drug-eluting stent using our proximal wire in the branch as a landmark. We've implanted at 18 millimeters. It expands very well. And of course, we're going to check our expansion on our pot with our SyncVision technology. And I think you'd agree that the balloon expands very well. So just finally, to check the results, we performed an IVUS. There's no distal edge dissection. We're checking our expansion. There doesn't seem to be any areas of significant or under expansion, particularly in the plaques, in the areas where we had a higher plaque burden, and there's no proximal dissections. Again, we're just double checking our areas on the co-registration technology, and you can do this at the table side. It's very easy to do so. And finally, we're checking our physiology results. So as you can see here, we've obtained a very nice physiological result. At this point, we've performed our second injection of the case, and I think most people would agree that it's a nice angiographic result. So here's just a reminder of what we've treated, and in total we used 9 cc's of contrast for this procedure. Patient had an uneventful recovery and is doing well in clinical follow-up. And just finally, I want to touch on dynamic coronary road mapping, because unfortunately for this case, it wasn't available on the day. But this is a very nice piece of technology. It's a very powerful tool which allows you to have real-time motion-compensated coronary road mapping on fluoro for the guidance of PCI. So it's created by injecting doing one angiogram, and you have this roadmap to then work with, and you can advance most of your balloons and stents over that. Thank you very much for your attention.
Thank you, Dr. About your indication for using ultra low contrast. I think one of the most important is fluidity, patient fluidity, not only the GFR. If the patient is frail, there was a lot of discussion about these patients usually are more born to go into contrast-induced nephropathy.
Yes.
Do you consider this in your...
Well, I think you need to look at the whole clinical situation. I don't think it's one thing. I think these patients, it's not just, as you very astutely pointed out, it's not just their eGFR, it's their other risk factors. If they're presenting in cardiogenic shock, they're going to have a higher risk. If they've got pulmonary edema, if they're diabetic, female patients, radial access. So there's a number of considerations, but I think the point is that we need to change how we approach these patients. There needs to be operator awareness, And, there's only some very small changes you have to make in your daily practice to incorporate these practices. So obviously, you may not go from a standard intervention to immediately jumping into an ultra-low or zero contrast. But if you make some small changes, you will see that your contrast volume will go down. And then when you need to use these techniques, when you have to really minimize your contrast, your patients with your EGFR less than 30 or other risk factors that puts them in a high risk, then you have your skill set to do so. You've got the experience to do so. So I think, most of these techniques are very simple, but the hardest thing, I think, is changing the mindset of the operators and increasing awareness. So, yeah.
Okay.
Sorry.
Oh, sorry.
Thank you very much for this nice lecture. Actually, I have experience with left ventricular end-diastolic pressure in our department, Alexandria. I have a thesis, and we published this in the abstracts in TCT that you measure with the peak tail end-diastolic pressure and the table. Sometimes you can make it by the echo. In our series, we do the echo in 300 cases before the end-diastolic if 13, 18, as you said. So it's very, very, very beneficial. The second, also we have a thesis about the dynamic roadmap. I agree completely, but if you have a machine with dynamic roadmap, it costs, I know it's a cost part software of Philips, only Philips. I think we don't have this is very important to use it in this cath lab with just saline and that's wiring. Thank you very much. You stress on this.
Thank you. I think the roadmap is a very powerful tool, and we're actually performing one of the first randomized control trials out of Clinico with it's a multi-center, multinational trial. So the results are coming next year, and hopefully they're going to show that this helps.
Okay, sorry, we cannot take any more questions because we are late and there is a live transmission in a very short time. So we have to conclude. It was a really interesting talk about ultra-low contrast, and I think that we should a little bit change our practice to reduce contrast media during PCI. Thank you.
Thank you very much.